Welcome to Reducing Risk, a series of podcasts from Medical Protection created specifically for doctors in Aotearoa, New Zealand. Reducing Risk looks at key medico-legal issues in our jurisdiction and provides helpful advice and guidance on how to manage those risks. Today we are bringing you a podcast where we are going to talk about some cases for our house surgeons or resident medical officer colleagues. My name is Dr. Chow Yen Chen, and I am here with my colleague, Dr. Lucy Gibbard, and we are both medico-legal advisors with the Medical Protection Society. Today we are very lucky to have with us Sam Beattie, who is one of the lawyers with our panel law firm, Wootton Carney. Hello everyone, and thank you for joining me today.
Hi, Tayan.
Hi.
Hello. So today we're going to talk about some situations that can arise in our work as resident medical officers or RMOs. And we're going to consider some medico-legal issues that can arise out of these scenarios. So both of these situations happened to me as an RMO. I was a second-year registrar in anaesthetics in a big tertiary centre, and this was about 15 years ago. So the first situation, this happened at night. I was the anaesthetic registrar on night shift. I was called by the cardiology fellow to consider giving some midazolam and fentanyl to a patient with conscious VT, so ventricular tachycardia, for cardioversion, and then reversing these medicines with flumazenol for the midazolam and then naloxone for the fentanyl. It was in the middle of the night. Lucy, what are some of the issues you can think of at this point? My thoughts at the time was that the cardiology fellow is more senior than me, and they were asking me for assistance. Could I just do as she asked, and she act as my supervisor in this case?
Well, if you're an anaesthetic reg and she's a cardiology fellow, the answer to that is probably no. Because actually you need to be supervised with somebody within your own speciality. And the cardiology registrar may not be aware of potential complications with that medication, or they may not be aware of the processes within the anaesthetic department. And so it's actually really important that the supervision you get is from someone who is in your own speciality and has got the expertise in that area to be able to supervise you. So no, the answer is the cardiology fellow is not going to be supervising you when you're giving anaesthetic medications.
Okay, so Sam, are there some specific medical council requirements for supervising a registrar?
So there are not specific guidelines that the council provide in terms of supervising a registrar, but what they will be looking at is that scope of practice, as Lucy said, and it does fall more on the supervisor. They are the senior in the situation. It's quite a process to become a specialist, and then you are registered with the medical council in that scope of practice. So certainly if anything was to go wrong, then the council might be looking quite closely at the supervisor who has left you alone. They'll be very interested in the scope of practice issue.
So I go and I assess this patient. Excuse me. It is about 2 a.m. I see an elderly patient. She's in her 80s and she's kind of sleepy. She's occasionally opening her eyes, but she's mostly just lying still. And she is surrounded by senior charge nurses. They're all very senior. They all have 3-letter acronyms. They're all like clinical charge nurse managers and ward nurse managers and clinical nurse educators. And this patient has ECG monitoring on via the resus trolley defibrillator. And they tell me that she doesn't speak English. There's one nurse present who can speak some Mandarin, and I can speak some Mandarin. But the patient's really not responding to me. She just seems very drowsy. Her cardiac rhythm is certainly in VT, and then the nurses let me know that she's been, and the cardiology fellow said that she's been in this rhythm for the past hour. She had no recordable blood pressure in the last hour. And the charge nurse tells me that the hospital protocol is to escort this patient up 3 floors in the escalator to the floor with the operating theatres if I want to give her any medicines and anaesthetise her for a cardioversion. So, Lucy, could you talk to me about the consent considerations here?
Yes, well, it doesn't sound like your patient is in a situation where she is able to provide informed consent. I mean, not only is the issue with language, but it sounds like she's not really responding and she's not actually really able to communicate even if the language is one that she understands. I also, assuming at 2:00 in the morning that she doesn't have somebody else there to help make that decision. She hasn't got a family member or anybody else there. No,
she's totally
just the ward staff. And look, I think in that situation where it's in her best interest and you've got to do something, you actually need to look at Right 7.4 of the Code of Rights, which is the part of the Code of Rights that tells us how to act when the consumer is not competent to make an informed choice of their own, and there's nobody other person entitled to make an informed choice on the consumer's behalf. And then it tells us that we have to think about what's in the best interests of this consumer. And I think we can understand that the best interest of this consumer should be cardioverted. Have you taken reasonable steps to ascertain their views? Well, you've tried to talk to her and she's not really talking, so I think you have. And then either if you can't, if you've found out what the consumer's views are, have you taken regard to those views? Have you actually thought about what they would want? And if you can't do that, is there somebody else around who could tell you what this person would want? And it sounds like in this situation, well, the nurses might be able to, but there aren't any family members. So I think in that specific situation where she doesn't appear to have the ability to communicate her consent or to understand what's happening, you have to make the determination of, is this an emergency where I have to act anyway? And then you have to take those things into consideration and decide whether actually, no, we haven't got time to get a family member to get involved. We haven't got time to get a competence assessment and see whether she's actually competent. Actually, we need to do something.
Yeah.
And then those are the steps that you'd have to go through.
Okay. So Sam, are there HDC cases or medical council cases around this issue of treating patients in an emergency situation when they don't have consent?
Yeah, so it's quite an interesting question, but happily there don't really seem to be many cases to the HDC or Medical Council, at least that I've dealt with, and I did actually ask some of my colleagues as well, and no one else could think of any cases. And I think it's, as Lucy's mentioned, you've got the HDC code, but you also have the Medical Council statement on informed consent, and that has a specific section on what to do in an emergency situation, and it's pretty similar to the HDC code. The only thing I would really add to that is making sure that you document really carefully what's happened and why you made the decision that you did. It may be, if there is some investigation later on, and if there is actually a poor outcome and it ends up going to the coroner, those notes will be really important to help justify the actions that you took.
Yeah. That's actually one of the problems, though. Often in an emergency, notes are the first thing that don't get written.
Yeah, exactly.
and so it's actually really important to go, because you don't actually have to write them while you're in the middle of the emergency, obviously, but you really do need to sit down at the end and think, I must write some notes on that, and write good notes on that, because I think often the clinicians themselves are pretty stressed and flustered, and often the notes is one of the things that doesn't get done very well.
Yeah. Absolutely. And, even if it is writing an email, putting it that way, doing a voice note, just something to get those thoughts down quite quickly after the event, they're going to be the most accurate recollection of what happened. Often we will see, it'll be weeks, months, sometimes years later, and you might be questioned about a decision. And by that point, your recollection is not going to be as good as it was at the time.
Yeah. So And I was really stressed. I talked to the nurses present and I said, this patient really needs defibrillation. It's really unsafe for me to take her out of this ward, take her in the escalator, take her up 3 flights of stairs. And my assessment was that I needed to defibrillate her there. But everyone there just said to me, they formed a line between me and the defibrillator. I still remember it. And they said, you can't defibrillate someone awake. They have to have some sedation. They have to have anaesthetic. And I felt really uncomfortable giving any anaesthetic medications on the ward. I didn't have them to hand. That was the first thing. So I'd have to leave, find my way to an anaesthetic department to get some medications and then bring them back to the ward. And I felt that as soon as I gave her any medication, she was likely to arrest, and I'd be left on my own on the ward, not being able to resuscitate or having to create this resuscitation situation. So I was facing this wall of resistance, literally. And I was wondering, do either of you have any suggestions for what I could do next? So let's say, Lucy, I phone you in the middle of the night and you're the advisor on call. What would you assess me? What would you advise me?
Yeah, I think that is a situation where people could consider calling MPS, but actually I think the first person to call is actually your SMO. I think that, it is very difficult in that situation when, especially when you're a junior registrar, the ward team don't necessarily know you very well. It's the middle of the night. There's another doctor there who's giving one piece of advice. Because they're looking at it from their speciality point of view, you actually are a different speciality and have different considerations, but that has created some conflict about what should happen. And that's exactly the situation where you actually need someone senior to actually, because I think there's often a real reticence to call the SMOs at 2 a.m. Because
absolutely.
some SMOs don't like being woken up at 2 a.m. and can be a bit grumpy. Yeah. But it is absolutely imperative. And if the SMO isn't rung, that later they'll say, why didn't you ring me? So I think this is a classic situation where you put down the phone to MPS and you pick up the phone to the SMO and say, look, I need help. Either you need to come in or you need to tell me how to deal with this situation.
Yeah, so I was like, okay, I tried to talk to the patient in Mandarin about defibrillation, but she was really drowsy. She's not really responding to me. And it doesn't help that it's in a different language because then the nurses present, like you say, they didn't know who I was. I was speaking in a different language. They have no reassurance that I was conveying the right information. And they just were really hostile about my plan, that, they just were really adamant. And it became quite heated. They just said, this is not right. You can't do this without sedation. So at that point, I left the room and I phoned my consultant and I said, this is what's happening. I need you to tell me what to do. I think I need to defibrillate this patient without medications and then support her after. But I have this people who are telling me I can't do this and I need help. So he just said to me, don't give any sedating medications, don't give her anaesthetic medications, and defibrillate her on the ward, don't move her. I'll support you. I support your decision. So again, I went back into the room. I tried to let the patient know what was happening in Mandarin. She didn't really respond, and so I let the nurses present know that I was going to defibrillate, and I set up the defibrillator, and I delivered a shock. And the patient, thankfully, reverted straight back to sinus rhythm, and then she had a recordable blood pressure. She was transferred then to the coronary care unit. And I wrote some notes about what happened, and I went back to the registrar room. So what would you think would be the risk to me if there was a complaint at that point, Sam?
I mean, so there is that point around consent that could be an issue. Although, as we touched on earlier, it seems like it would be relatively unlikely in this case. I don't know if the patient was sort of aware enough to possibly make a complaint about how she felt about having that being done to her without the sedation medication, but that could be something that came about, or possibly even the family, once they'd spoken to her, may have some concerns about her comfort, and then also, later down the line, as I said before, the documentation. If the documentation is not up to scratch, then you could get in a bit of trouble for that if you needed to be relying on it later and it wasn't satisfactory.
Yeah. And I went back the next morning to see the patient in coronary care. But the nurse I met there told me that, the patient was defibrillated awake and how traumatic that must have been for her. So at that time, I was really concerned about getting a complaint from the nursing staff for doing that on the ward. I was really worried that, I was going to get a complaint from the patient for not giving her any sedating medications. So I didn't see the patient and I left. And for the next few months, I was really always worried that I'd be phoned up and, there'd be a complaint from the nurses. And then I was worried that, that because I didn't follow hospital protocol, I'd be kicked off training, and I was catastrophizing a lot in those days. And so, Lucy, what would you have said to me if I'd phoned you up and I said, I'm really worried about this. This is what happened. And I'm worried that I, didn't do the right thing and I'm going to get a complaint.
Yeah, and look, I understand how that feels, that worry that a complaint's coming. I think the first thing I'd say is well done for not giving in to the pressure that you were feeling, because often as junior doctors, when there's pressure from senior nurses to do something, we often think, oh, look, I'll just do it. But actually, that is often the wrong thing to do, or it can be the wrong thing to do. And it's really important that you don't act because you feel pressurized. You have to act based on your own clinical judgment or that of your SMO, basically. Yeah. So I would say, well done for calling your SMO. That was absolutely the right thing to do. Well done for not just giving in to pressure to do something that you thought was wrong. Goodness knows what would have happened to her non-existent blood pressure if you had given her some sedative. And, as you say, you may have been ending up with a lot of worse situations. So good for you for that. I probably would have said, look, your instinct was to go and talk to the patient the next morning, and then meeting the nurse made you turn round. But I'd have said that instinct was probably a really good instinct. And that actually following up with patients after something hasn't gone as well as you would have hoped is actually really important. It's hard. There's often a lot of reticence. We're often really worried what the patient's going to say. We're often very scared about what the patient's going to say. And so we often avoid, that's natural withdrawal response that we have, an avoidant response that we have. So we often don't want to go and talk to the patient. But it's really important that you do. I also think it's really important you sit down with your consultant and actually say that this is all what happened. I found it really difficult. How could we avoid this? Did I do it right? Give me some feedback. Is there anything we would have done differently or we could do differently next time? Is there something we need to change within the processes to make it clear that if a patient had no recordable blood pressure for an hour, that actually starting moving them around the hospital or anaesthetising is not great? And then I'd also say to my consultant, would you come with me to see the patient? Because I actually think going to see the patient alone, now, it helps to have a senior colleague when you're having those conversations. So I think I'd say talk to your consultant, go and see the patient, call MPS. You've done that. Good on you. And actually talk to MPS, what should I do? And we'd probably say, go away and write down exactly what happened now. And even, you can write it in the notes, but you can write it anonymized somewhere else that you keep for yourself, a very detailed account, because often you're not going to want to write about the conflict with the nurses in the patient's notes, when you shouldn't. But actually, it's really helpful if the day after that's happened, you've written a really long account of what your motivations were, what your thoughts were, what the process that you went through was, all stuff that may not be in the notes, but is actually going to be really helpful.
And yeah, I definitely second that. I've often given advice to practitioners. Look, if there has been some sort of conflict or there's something that you don't want in the formal record, but it might be important later if you receive a complaint, if it goes to an inquest, anything like that, having that contemporaneous account is very important.
Yeah, so you would support keeping the conflict documentation separate to what's in because you need to document properly in the notes, the patient notes, but still not be pointing fingers or...
Exactly. So I think it might be important to record, say, the nursing staff suggested this, I spoke to my SMO and I followed what he proposed. But for your own protection, I guess, I would separately document something that perhaps is a bit more detailed, just in case. Hopefully you don't need it, but it is better to have that there, especially in a he said, she said sort of situation where obviously it was very stressful. It's the middle of the night. There are lots of factors. So getting down what happened can be really useful.
And keeping it anonymised, so that you don't have to have any identified details on it. And I think that's and sometimes emailing it to yourself, which date stamps it,
yes,
can be a thing. And letting your SMO read it, and because it does always help at the end of something that hasn't gone so well to actually think, okay, could I have done that better? We are always learning, and maybe your SMO will look at that and say, yeah, this is, maybe you could have done this instead. I mean, honestly, not an anaesthetist, have no idea what else you could have done, but your SMO might have had some ideas.
So Sam, would you be able to talk to us about how, because I was registrar in that situation and I did phone the consultant. They didn't come in, but they gave me advice over the phone. So say if there was a complaint, how do regulators approach this dynamic where, you sought advice, but they weren't there, so they're relying on your expertise?
So, look, when you're a registrar, particularly at the level that you were, you're still fairly new and you're learning the ropes. And particularly in a hospital setting, you're not alone. There are other people there who are supporting you and should be supporting you, and you have a supervisor to help you with those difficult situations. So regulators, whether it's the council or the HDC, will frequently recognise that something like this, if a complaint comes up, is more of a system issue rather than it being because you have done something wrong. And it's often outside of your control. There may be occasions where a registrar is criticised or where their sort of competence or conduct is considered, but those situations are rare and you usually have to have done something quite wrong. So, for example, you might have not called your SMO at all and just gone ahead despite the resistance, and maybe that was the wrong thing to do. You should certainly be seeking that support, or if you went against what your SMO had recommended, then you might be in more trouble. But generally, it is recognised that as a registrar, you are fairly low down in the food chain, and there are other people, and in the hospital there are systems, and so it can't be all your fault.
Okay. And the same kind of applies for house surgeons when they sought advice from registrars, doesn't it? It's the system will look at the person who is being supervised and the supervisor as two separate entities, won't they, and see who should be. The other thing I was actually just thinking about with this was actually if it's something that was significant, do you actually initiate a significant event process? Because sometimes that's a way of actually addressing it formally. I don't know, sometimes it will escalate it and it would be better to do it on an informal level. But actually, if you think that the protocol was wrong, or it needed augmentation, or maybe a significant event process is a formal way of saying this event needs to be reviewed.
Yeah, and I certainly think at my detriment, I didn't get feedback from my consultant after, because I think that would have been really helpful. But I was really concerned about how critical the nurses were, so I was afraid, and so I didn't get that feedback. But absolutely, I think SMOs are very resourceful. They understand the system that they work in, and they'll be able to advise what you could do to prevent that interaction happening again.
But also with the patient, if she could remember that event, it might have been really helpful to sit down with her and say, this is why I did this, get an interpreter in, get your SMO in, I think you can avoid a lot of complaints if after something hasn't gone so well, you actually sit down with the patient and explain what happened and why you did what you did. And even if actually in retrospect you could have done something different, you can explain why you did it and why you thought it was the right thing at the time. And I think, your fear there's a complaint coming may have been totally alleviated if you'd actually talked to her and actually she'd said, no, that's all right, I'm really grateful that you did defibrillate me and you essentially stopped me being in VT. That was a good thing and I appreciate it, and I realise it was a difficult situation. She may have been totally fine with it and you would have saved yourself months of worry.
Yeah, absolutely. So I'm going to talk about a second case, which also happened at night, good old night shift. I was in the same hospital, and I was that same year. It wasn't a great year for me, doing lots of night shifts. So in the middle of the night, I was the obstetric anaesthetics registrar. I was called to assess a patient who's in the last trimester of her pregnancy, and she was admitted for severe preeclampsia. So for blood pressure management, she had high blood pressure. The blood pressure was about 180 on 100, and she was on Clexane treatment to thin her blood, and she had renal impairment. And the obstetrics registrar called me to say she's bringing her for an urgent caesarean section because the baby had developed fetal distress. And she emphasised to me that the baby needed to be delivered straight away because there was fetal distress. So, Lucy, could you tell me about the potential risks of me just progressing and proceeding in the middle of the night without consultant support, given that at the time I was the only anaesthetic staff on site, no time to call the consultant in because the baby was in distress, and the consultants, they're on call from home and they're about 30 minutes away.
And look, it's really hard when you're in the hospital at night and the help is far away because, it depends on your level of experience and skill, whether or not you think this is something that's within your scope of practice to do unassisted by an SMO. And I'm guessing as a second year registrar, you were concerned about your expertise to actually handle a patient who is hypertensive and having, in that preeclamptic situation and is going to need an urgent anaesthetic. So the answer is you've got to look at that supervision. What supervision have you got? If you haven't got someone hands-on, how can you get some other form of supervision? Even if it's by phone or, getting advice. I think it's really important that the seniority of the trainees who are on at night is acknowledged as, not always being of a level that they can do everything.
Yeah.
And then you've got that problem of the callback time because if you've got, I know some consultants, when they have very junior registrars, they actually stay in the hospital because they're thinking, actually, this very junior registrar, it's not safe for them to be in the hospital by themselves. And as the registrars get more and more senior, the consultants get more and more happy with staying at home.
Yeah.
But I think that's something that you probably need to talk to your SMO about at the start of a run.
Yes.
And say, look, this is only my first time doing this. I haven't got a lot of expertise in obstetric anaesthetics. What do you want me to do if there's a significant problem while overnight when you're not here? And so maybe preload that discussion so that you've even thought about it, and so that they're aware what your expertise level is, and that they're aware that they need to maybe be a little bit more available until you've actually got that experience. And again, doing that at the start of a shift, because the way the hospitals work now, you may be working with different consultants all the time. It may be a locum, it may be somebody who doesn't know you. So at the start of the shift saying, look, this is my experience, this is what I'm up to, this is what's on delivery suite at the moment, I'm a little bit worried this might be coming. So you actually plan for it as much as you can. I know it's an emergency. And look, if you think, you've then got to weigh up what is the safest option for this woman, what's the safest thing to do, what's in her best interests. The consultant's 30 minutes away, not going to be able to do this. So then you weigh up what is the safest way to proceed, and then you document that the considerations that you took to actually come to that decision. Yeah. And you do a very careful consent. I have to say, it's one of the things that the HDC are very keen on, is making sure that the consent process is done well. And I think in obstetrics, it is really hard because the time pressure is extreme in obstetrics. And the woman may have medication on board, which makes her maybe sleepy or something like that. She is under extreme stress, probably the most extremely stressful day of her life. Yeah. And so actually having time to be for her to understand and ask questions and be properly consented, it's really hard. So I think doing the consent as well as you possibly can do is really important as well, even though it's an emergency. And it's actually quite useful if the woman in that situation has family members there, that you actually involve them in the consent process, because often she won't even remember later.
That's right.
And I have had cases where the woman says, I don't remember any of that consent. And it's like, well, the doctor remembers doing it. Well, actually, maybe it did happen, but the patient was so stressed and had medication on board and all the rest. It's really difficult. So having family members or other people there for the consent process, nurses, other people who can actually say, yeah, that was done as well as it could have been done within the time available, I think would be really useful. And if you can, say, have you got any questions? Is there anything, give her time to ask questions if you can.
Yeah, so I was seeing this patient. She's really hypertensive because she's stressed as well. Now she's about 190 systolic. And the obstetric team bring her to theatre because they're like, this is an emergency and this baby needs to be delivered. So I was really concerned about the high blood pressure. From my training and study, I knew that before I give her anaesthetic medications and then proceed to intubate her, I need to get the blood pressure down because there are risks of intubating and proceeding in that situation with a really high blood pressure. So I was worried about a risk of intracranial hemorrhage from uncontrolled high blood pressure during intubation and the start of surgery. And because she'd had Clexane, like this is a clinical aside, but because she had Clexane, usually we put in a regional anaesthetic. But in this situation I couldn't because she'd had Clexane because of her preeclampsia. So I couldn't do that. And the obstetric registrar and the obstetric consultant who'd now come in were really, really hovering. They sort of stood over me and they said, you need to get on and induce this patient. We need to deliver this baby. And the patient was awake and they kept saying, oh, you need to start. We need to deliver. We don't have time. So, Sam, what do you think the potential risks to me would be if I proceeded in that situation without acting in a clinically appropriate way? So if I knew that, there are certain clinical parameters that I need to stabilise before I started, and I didn't, and I just proceeded, what do you think would be the risk to me?
Yeah, so I mean, the risks here, again, as we've sort of previously talked about, I guess proceeding without supervision, and as Lucy said, even if you can get someone on the phone, that's probably a good starting point. But if the outcome is bad and you've proceeded in a way that isn't clinically appropriate, there's quite a lot of risk to you here. I mean, firstly, as a registrar, there may still be a sort of system review. Was it appropriate that the SMO was so far away? So you may still be okay, but, there might still be concerns about the safety of your practice. And that might be looked into further. You might face criticism if a complaint is made to the HDC. If it went to the medical council, they may look into your competence, for example. There is the potential, if they're really concerned, hopefully wouldn't be the case if this is sort of a one-off situation, but, they can impose conditions, and there may be things around supervision if they're worried that you are it's more likely if you're continuously acting in this way rather than a one-off, but there are some risks around that as well.
Yeah. So I was really struggling. I didn't have enough time. I felt like I didn't have enough time to bring the blood pressure down to a safe level. So at that point, if I picked up the phone to MPS and I phoned you, Lucy, what would you say to me?
This is going to be the same as last time, Jenny. And I'm going to say, I'm not going to be very useful. This is a clinical situation. You need your SMO. I would tell you to call your SMO and get your SMO to support you in what is the correct way to proceed. Often that will help, having SMO to SMO with your SMO on the phone telling the obstetric SMO it is not safe to induce this patient until we've got the blood pressure right. Yes, I know the baby's struggling, but actually the mother's health is also important. And, sort of supporting you in that might have actually been very helpful.
Yeah. So I just didn't know what to do. But I knew I needed to call my consultant. So I picked up the phone and I phoned them and I put them on speaker and I said, I need you to tell me that I need to bring down that blood pressure. Or you need to tell me how to manage this blood pressure before I induce this patient. And they repeated it back to me and they said, you need to do X and Y and you can't start until the blood pressure is X or Y. Yeah. So I put the phone down and then I started to bring the blood pressure down and the blood pressure readings show up on the screen. So because they'd said that out loud to me on speakerphone, everyone just watched that blood pressure come down. And then as soon as it hit the acceptable level, I induced the patient. And the baby was delivered and mum was fine, baby was fine. But same situation as in the previous case. I felt really worried that I'd be criticised by the obstetric team for not acting, in an expedited way. And not inducing the patient for an emergency caesarean section when the obstetricians have said this is really urgent and you need to do that. Again, I didn't go see mum or see the baby after, and same again. I didn't get feedback, and I just felt like I was going to get a phone call any time. Big complaint from the obstetric team. Yeah.
And look, I think as we talked before, I think talking to your consultants after the event is really important, both for your learning. And I think it sounds to me like you were worried about even doing that. When you're in a very heightened state of anxiety, it's not nice having to go and say, tell me if I did something wrong here. You know, we feel very vulnerable and we tend to avoid things that make us feel that way. So, and it's the same with talking to the patient, you know. Definitely better to talk to the patient, not always by yourself, often with your consultant, but actually we don't want to do it because we're worried what we're going to hear. But so often, actually, if you sit down and have a good talk, the patient really appreciates it, and it actually will make you feel better too. So I really would encourage all our listeners out there, all the RMOs who are in or might be in similar situations, you know, talk to your SMO first, but actually, and talk to MPS too, because often it's really important you don't go and see the patient and put all your anxiety and stress on them. You know, that actually you're going to see the patient for the patient's benefit.
Yes.
And so you need to debrief with someone else first. You need to deal with your own anxiety and your own feelings first. You don't load them onto the patient. You're there to tell the patient what happened and see if they've got any questions and answer them. So that's why it's not great to instantly go to the patient. You need to be able to deal with your own feelings and get some feedback from a colleague first, so that when you do go to the patient, you're calm, you know what you're going to say, and the patient recognises that you're there for their benefit, not yours.
Yeah, that's so true. Yeah. And, you know, I was talking to my colleagues about these cases, and I think we often overlook how important it is for our RMOs and our surgeon colleagues to have responsibility and to learn from having responsibility and acting properly in that situation, and to put the supports in place so that we can learn in a safe way. Because it's really important part of learning. You can the only way you'll gain experience is by having to make decisions and to grow in your medical practice. But it's really important that you seek proper advice so that you're safe when you're practicing, and that you ask for help and you ask for advice when you feel stressed and pressured and that you're not sure about what to do. And certainly for me, I definitely recognise that a lot of clinical work carries a huge mental load if it's not addressed properly, and it just plays on your mind. And I see the importance of a proper debrief now as part of learning, and as a part of learning from responsibility as well. So, like you say, we shouldn't forget about the patient in all of this. And I think that if I'd gotten up the courage and taken the time to return to the patient and follow up with them, I think I would have, you know, been able to communicate about the care I provided and why I did it. Do you have some comments for me? Some comments for our listeners?
Yeah, I mean, I think a lot of this sort of does go when you're in that hospital setting, sort of appreciating the benefits of that there are other people around, that you've got, you know, a consultant with lots of experience who is there to help, and that you should be well supported in those environments, and that, you know, in most cases it will be recognised that you are junior, and that there are people above you who should be able to help you, and that anything that does go wrong is typically more of a systems issue. I mean, in a lot of these cases, when they go to the HDC, it's the hospital who faces criticism because there is some issue with the system, rather than individuals, and particularly the junior doctors will very rarely get in any sort of trouble. And then the other thing I would take from this is, you know, the importance of notes, and, you know, having good notes in case you do have to, you know, justify yourself at a later date, whether that's for an internal process, if there's a complaint to the HDC, if there has been a bad outcome and it goes to the coroner. Always, you know, document everything and be able to explain why you've acted in a particular way.
Yeah.
Yeah, and I think one of the big things. And I think we say, oh, you're supported by an SMO, but sometimes in the middle of the night, you don't feel very supported by the SMO. There are some SMOs who don't want to be woken up. And so I think that in an ideal world, that would be the case. But I think it's really important when you get to a point where there's a situation where you're not sure what to do as a junior doctor and you're thinking, it's 2 a.m., I don't want to call my SMO, they might be upset with me, they might be grumpy. I think you have to take a step back and think, yeah, they might be, but actually there's a real patient here. And the biggest risk to you is proceeding when you're not sure without getting advice and something going wrong.
Yeah.
So yes, you may have a grumpy SMO if you ring them. Hopefully not, and the SMOs understand that that's what they're there for. But, you know, I know there are situations where the SMOs may be not as happy about being phoned. But actually the worst outcome is thinking, I don't know what to do, but I'll just have a go anyway because I don't want to wake my SMO up.
Yeah.
That is the worst. And so actually you have to do the right thing, think about the patient, and call the SMO, get advice. And then afterwards, try and debrief that really professionally and talk to the patient.
Yeah. Wow. Thank you, Sam and Lucy, for joining me today. Thank you also to our listeners. I hope you found this podcast useful. If you enjoy our podcasts, please subscribe and like them. If you have any suggestions for other podcasts or helpful feedback, please email us at nzpodcasts@medicalprotection.org.